Amazing. So again, my name is Brooke Gordon, host of Best for Women Live, and I'm so glad that you can join us here today. My guest today is Kim, who is a naturopath, and really excited to have her come in and join us. Let me see if I can send. Are you going to work for me, Instagram, today? Here's hoping. Oh, perfect. Here she is. Hello.
Hi, Brooke. How are
I'm
you?
wonderful, Kim. Thank you so much for coming on today.
Oh, thanks for having me. This is a nice little touch to my Monday. And how are you?
I'm doing extremely well, thank you.
Yeah.
I was just saying, one of the things that was really interesting for me is
Mhm.
learning a bit more about some of we're going to get into an intro for you, but
Mhm.
I'm really excited about this topic because I think not enough people know what PCOS is,
Mhm.
not enough people know, women in particular, about how it can present and show up in the
Mhm.
body, and how many people might actually be living with
Mhm.
PCOS and not
Right.
even know.
Mhm.
Absolutely. So,
Yeah.
Kim, do you want to take a couple minutes and just introduce yourself and say hello and tell us a little bit about why this is an area for you of expertise?
Of course. So, yes, my name is Kim. I am a naturopathic doctor based on the east end of the GTA. So, I'm kind of all over. I'm in Whitby, I'm in Scarborough, I'm working virtually, and next month I'll be starting at an actual fertility clinic in North York. So, yes, on the east end of the highway, you'll find me. And as a naturopathic doctor, what I basically do is I provide integrative reproductive health care. So for those who are struggling with reproductive health issues, my primary focus is on fertility and pregnancy, but I also support a lot of people going through perimenopause and contraceptive issues or menopause and even for teens. So like it's a whole spectrum of things. What personally drew me into this line of work is I also struggled with reproductive health issues myself from when I was much younger. I have PCOS, but actively managing and thriving, I think, with it. And I think the world needs more awareness and support for themselves. I totally understand that not everyone is able to access the type of care I provide. So, to the very best of my ability, I try to do all these things where you are able to share awareness about complicated issues like PCOS. So that's where I am. That's who I am.
Amazing. Amazing. So I want to pause for just a moment to say
Of
PCOS
course.
and see if I understand it correctly.
Yes.
It's polycystic ovarian syndrome
Yes,
or
that's correct.
symptoms? Syndrome.
Syndromes.
Okay.
Yes. Yeah.
And so what is a polycystic ovary and why is that a
So
thing?
yes, a little bit of context. So the name itself implies that everyone who has that diagnosis must have ovaries that have a lot of cysts, so polycystic. But we've come to realize, as growing number of professionals who specifically look at this condition, is that you don't actually need to have polycystic ovaries to be diagnosed with PCOS, which is very confusing because it's in the name. But anyway, the actual issue is that it's a very complex hormonal disorder wherein you are not able to ovulate. Right. So it's an ovulatory disturbance issue. And you primarily present with signs, symptoms of high androgen levels, which are, male hormones like testosterone. So, and this is where it gets a little bit more familiar, where people actually go through these signs and symptoms of what we call hyperandrogenism. And so those two are the main criteria for PCOS, is that you have like signs and symptoms of ovulation issues, and you have signs and symptoms of higher than normal androgen or testosterone levels. So, then you have that same characteristics of PCOS. It's just that you don't have to have polycystic ovary. So, in the PCOS community, that's a growing topic of conversation too, wherein like, should we invest in renaming the syndrome, or should we invest in so the the funding for developing cures and discoveries for PCOS related things? It's more like, oh, should we actually rename this, or should we invest in more awareness causes and treatments and all that? So that's another thing. I don't know if people
Interesting.
are aware.
Wow,
Mm-hmm.
because naming is something really
Mm-hmm.
important. When you're able
Mm-hmm.
to identify and actually put a name to it, there's a lot of
Mm-hmm.
comfort, I believe, that
Right.
can come
Yes.
from that.
Yeah. Yeah.
So
Exactly.
if I didn't know, if I was just not
Mm-hmm.
feeling well, right?
Mm-hmm.
And or I just didn't feel like things were quite right, what
Mm-hmm.
would I be going to my doctor? How would I even know? Like,
Mm-hmm.
how do I know that I would have any of
Right.
those symptoms? What do the signs and symptoms look like from the inside? Like, how
Right.
might I experience that? Or what was your experience? How did
Yeah.
you get diagnosed, if you're comfortable to share?
Of course. So, for myself, I'll start out with myself. So, the way I realized and was diagnosed with PCOS, it took me maybe 10 years to really get a final diagnosis of it. So I've always struggled with very unpredictable periods, more so to the sense that it's not as regular. But I would have the same type of cycles, just not like, I don't know if it's going to happen in 3 months, next month, or 6 months. So I've had stretches of time where that would just not happen. So that's a common symptom of PCOS, where you have irregular periods. Another more common symptom and sign of PCOS is weight gain is something that can be very common for a lot of people. So ovulatory disturbances, this also looks very different. So for one person, it can look like irregular cycles. For another, it could be extremely unpredictable cycles. You get it month to month, but it's like one moment you're like a crime scene, you're gushing a lot of blood, and then the other you have very light periods. So that can present as such. Another,
Sidebar, just
yeah,
quick.
yeah,
I
of course.
discovered that
Mm-hmm.
I've never heard it called a crime scene, but yes,
Mm-hmm.
and I discovered, I believe it's called hemorrhagia.
Yes.
As yeah,
Or,
I was diagnosed with
or
that last summer.
menorrhagia.
It
Menorrhagia,
was
you mean?
menorrhagia.
Yeah, yeah,
It
that's right.
just felt like it was the right word because it involved the
Yeah.
word rage. And one
I
of the
love
nice
that.
things, the specialist I
Mm-hmm.
was seeing at the time, she's like, and you experience flooding. And I'm like, flooding is a good word. It's so grateful to be working from
Yes.
home because I can sit
Mm-hmm.
on a bath towel and I have access to a
Right.
tub, because it does
Mm-hmm.
actually kind of, yeah,
It's like a flooding.
it's
Mm-hmm.
awful when it
Yeah.
happens.
Mm-hmm.
Yeah.
I've heard like
Okay.
there's many ways to describe it, like flooding, crime scene. Oh, I've heard different words, so I don't know why crime scene came to mind today.
But it's a very valid description. Very valid
Yeah.
description.
Mm-hmm.
May I just quickly, because I want to hear
Of
more about your
course.
story, but does
Yeah.
the idea of the rupturing cyst, so the fact that you
Mm-hmm.
have even had a ruptured cyst in your
Mm-hmm.
ovary likely
Mm-hmm.
means that you have ovaries with cysts. Are
It
they
can be.
connected? Can be. So
Can
not
be
necessarily,
connected.
but possibly.
Hmm.
Okay.
Yes, yes. So, the ruptured cyst, like that can happen to any person with ovaries, right? So, but it doesn't it may increase your risk. If you have like polycystic ovaries, it may slightly increase your risk of having ruptured cysts, because then you have multiple cysts that are like, just potentially ticking time bombs, but not necessarily, right? So that one we don't really know. But essentially it's not really part of it. Used to be part of the criteria before you get diagnosed with PCOS, but it's more even people who have normal hormonal profiles, normal cycles, no fertility challenges, some people would still have polycystic ovaries. And there's that. Teenagers have polycystic ovaries, very normal. And it's more just, I think what it's more if you go to a doctor's office, the primary conversation would be, what are you struggling with, right? And then there's that in-depth exploration. But for maybe most people who don't really have a concern to begin with, and they come into a doctor's office, like there might not be an adequate conversation about what's normal or not. So yeah, right. So it's realistically speaking, in our healthcare appointments, you don't really go in there just for like a wellness check. You're coming in there with a concern. Yeah, I mean, like to relate that to PCOS, again, what you're looking for is more likely than not menstrual cycle disturbances, irregularities. And then the other part that I was telling you about was that high androgen levels or testosterone. So that looks like so weight gain is one common manifestation of that. Another is acne. Another is facial hair growth. So it could be like maybe hair kind of popping up in your chin, your jawline. Sometimes it could be by the abdomen. It could also be head hair loss on the other hand, right? So you're growing hair on your face, but losing hair on your scalp, right? So that's another. Something that's a little bit more advanced is where you get discoloration in your skin. So this is what we call acanthosis nigricans, wherein there is that kind of like a that hyperpigmentation that's happening. So that's another sign of that. But yeah, like you first, a lot of people they feel like, okay, it's just normal, it's in my family, like I'm just gonna grow up this way, right? So it's heavily normalized because there's that lack of awareness still for the most part. So
I'm going to agree with you 100% on that part.
Yeah.
Last summer in my 40s, finally diagnosed that perhaps a 10-day period that's that heavy is a problem.
Oh yeah. That's a lot of days of flooding and rage.
Well, and the only reason is it was actually the exhaustion. It turns out I now have low iron, and that's actually what triggered the conversation with the doctor. I can't make it through a workout. Something's not quite right.
Oh, I'm sorry. That's
no, I'm being treated. Yeah. It's fine. But it's interesting the same time. Oh, well, that's not normal. What do you mean that's not normal?
Right.
It runs in my family. It's normal for my mom, was normal for my great aunt. Why wouldn't it be normal for me?
Right. Yeah. So it's just like there's so many gaps, right? There's so many, I think, conversations that could prevent a whole slew of things. Let's just say. And PCOS is, while there's no cure, I think having that awareness early on is so important, right? And and that's why we're here, right? Like we're kind of sharing that, oh, this can present this way, and it's just good to talk to your doctor about it or talk to someone about it, right?
Oh, I love this. Okay, so things that I'm hearing is part of it is that it's complicated and complex. It's not the same for every person. And so it can take a really long time, in theory, for your care provider to come to a conclusion or a suggestion that perhaps this is your diagnosis.
That's the
fair statement.
Reality for a lot of people.
Okay.
Yeah, fair statement for sure.
And then what?
So I think on our end, because for myself, I can't really provide like advice for everyone. I don't know everyone's history. So what I end up doing is in this maybe scale of awareness, like being aware. Awareness is the best thing that you can use for yourself to kind of see like, okay, am I experiencing these set of experiences that are supposedly normal? Then if not, then that would be grounds to warrant more investigation and care, right? So on a menstrual level, for people in their reproductive age, like if you haven't hit perimenopause yet, I think understanding the normals of what your premenstrual and menstrual experiences are can be a game changer for a lot of people. So I will just start off with the fact that anything that's severe, that's that's progressively getting worse and that's debilitating your day-to-day is never normal, right? That's also something that's, again, heavily normalized in our society, which has to be scrapped. So premenstrually speaking, some people might experience none at all, or mild degrees of maybe some breast tenderness, a little bit of cramping, some tiredness, nothing debilitating, right? So if that becomes an issue, then see someone, seek help, right? Same thing with menstrual experiences. Ideally, you want to have maybe 9 periods every year, because even in healthy people, like it can be normal to skip a cycle or two. But if it's like, more than the half of the year you're not getting your cycles, then it does pose risks, right, for complications in the long run. So you do want to have that help right away. So there's that. On the other hand, those cycles, 9+ cycles every year, they should be generally consistent in how they present every time. So if you're feeling like every month is so unpredictable, just get help. Just get some questions. Again, just get some investigation started, because that should be a predictable and otherwise, uneventful experience. Like you're right for you, and it doesn't have to be such a, you don't have to put the red carpet all the time for your period. Like you can definitely be functioning and like close to your normal self when you're on your period. So there's that. In terms of bleeding, I know you said you had 10-day periods, so that's a tad bit long for what's normal. So I hope that gets shorter for you, so you don't lose so much more blood. So we're looking at maybe 3 to 7 days of bleeding. And people with PCOS, people with no PCOS, sometimes that can be an issue, sometimes not. So if you do expect to see like some heaviness in the beginning and then it tapers down towards the end, which is totally normal. But there shouldn't be significant blood clots too. So that's another thing, right? So you never really want to have like huge clumps of tissue. It's very normal to have like some tissue strands, but nothing like that's like coin size, so because that's pretty significant.
Or bigger.
What else? Yeah, or they're big. Okay, so that's quite a bit, right?
Uh-huh. Yeah.
We'll talk. But yeah, so that's another thing. What else? The flow, the bleeding length, the heaviness. Oh, heaviness is one thing, right? So it's one kind of parameter for heaviness is like how many days you're bleeding, but it's also the actual volume. Now, most people will not really make the time to to know how much blood you're losing every month. But in studies that do look at this, we're averaging about 80 to 120 milliliters of menstrual blood loss every cycle. That seems to be normal.
What would that be? Like, yeah, because most people can visualize a teaspoon or a tablespoon. Yeah. So what, or a cup. So what sure. Like what kind of volume would that translate to?
Of course. So that would be like, so I can give you some context. Like, if you're using pads, I think like a regular absorbent pad would hold maybe 5 mils of blood. A super absorbent pad would be anywhere from 10 to 15 to 20 mils of blood. So, and then same thing for the absorbencies of tampons. Like you would probably hold the same amount of blood. And then it's a little bit more straightforward when you have a menstrual cup, right? And then it's also a different story if you're free bleeding. So you might not be able to really quantify that as easily. But anyway, for people who use pads or tampons, you're maybe looking at changing a fully or mostly soaked tampon or pad every 4 to 6 hours, right? So if you're changing more frequently than that, then, it is reasonable to presume that you may be losing more blood than that 80 to 120 mil average, right? So which further requires more workup and investigation. So there's that heaviness quantity. Hopefully that gives some people a little bit easier time to visualize without using a measuring spoon.
Oh, it's an awesome visual. I didn't even think like how many pads would that be in a day? I'm like, well, I'm thinking like I'm an engineer. I'm thinking volume.
Yeah. Volume, there's definitely different ways. There's probably stuff that I haven't thought about it, but that's
it's perfect.
Common conversation. But yeah, so that's the heaviness part. And then cramping, mild to none is great. If it's severely debilitating, again, get help, right? Like get some just straighten things up, like understand like why you may be going through some significant degree of pain. And that should also lead to further an exploration of your health issues potentially. So that's I think that's done, right? Like the heaviness, and then the flow, the duration. So if you are falling out of that, that kind of spectrum of what is normal, again, that I think that would offer some touch points essentially for discussion with your healthcare provider. So that's where it starts, right?
I love this. Can we pause for just a minute to recap? Because I think this is really helpful. Like I think I've got a picture in my mind right now. There's an account that I follow that talks about like, what's not normal that is normal. And so some of this idea of ways that it could be presenting. So yes, if you have heavy periods, irregular periods, pain full stop is not
Pain.
necessarily
Yeah.
normal.
Yes.
Looking at just the
Yes.
inconsistency within a given 6 month to 6 to 12 month spacing.
Yeah.
Is there a lot of inconsistency? Because it doesn't
Mm-hmm.
have to be 28 days. That's what
Yeah.
I'm hearing.
Yeah.
That's not
Yes. Yeah.
necessarily correct for everybody, or
Yeah.
the thing for everybody. But this idea of sort of 9 out of
Yes.
12 months. So that's a great indicator.
Mm-hmm.
Some of the other things that I heard that I think are really helpful is this idea of hair loss, weight gain, and then having body
Right.
hair. So around the abdomen, you talked about sort of on the jawline or the chin. Is there anything else along those lines that, you know, are symptoms that you see that are fairly common that people present that would be maybe, this maybe not to diagnose, but this is a good starting point for more investigation and conversation?
Yeah. So often, like, I'm not really limited to just talking about like people's reproductive health, right? So often there's an element of like high stress, maybe some consistency with poor eating habits or just suboptimal, dietary intake, if anything. There's sometimes an element of, sleep quality issues. So it can be a combination of things. One thing that's fairly common for PCOS presentations, because it's not just like, bigger people who have PCOS, like people who are on the smaller side can also have that. So what seems to be common ground is not just the testosterone being on the high end, but also the element of insulin resistance seems to be a very common thing. And this can present as if you're familiar with hypoglycemia or hyperglycemia, so like blood sugar level fluctuation issues. So sometimes you may come across people who have lots of headaches or feel like, very lightheaded at all times, a lot of sugar and salt cravings, right? So they're not necessarily indicators of PCOS, but they can be indicators of another underlying hormonal issue that could worsen or exacerbate someone's PCOS presentation. So it's a really great question to ask, but yeah, it's a little hard to kind of generalize because it's not a cookie cutter diagnosis at all. Everyone presents a different way. It's just like the commonality is that yes, there's ovulatory issues, there's maybe some fertility challenges for people looking to conceive. Most people I see who are just getting diagnosed with PCOS, they just discover it because they're just about to try to get pregnant, right? And then it's like, oh, I've been having this for a long time. But anyway, and then in some people, like this might be something we talk about, oh, in hindsight, oh, maybe I was struggling with PCOS, and this is for like perimenopause, or for people who might have IBS or menopausal issues, right? Not just like the perimenopause, but actually going through issues after menopause, right? So it's a hard thing to kind of just generalize because there's no one right presentation, if that makes sense. So yeah.
Yeah, it is. And what I'm also hearing is some
Yes.
of this, I'm going to call it the complexity, is because it does have a hormone base to it. And so here you're getting into insulin challenges, you're going to get into the liver, all of these other systems in the body that are, they're all, like, it's still one body.
Yes, it is. It is definitely. Right. So, so maybe you can kind of tell by now when I have my appointments, there's a lot of information that gets laid out, like this connects to this might be impacting your symptom right now. So yeah, there's a lot of touch points, that's just say, of how PCOS can relate to different other conditions too. So yeah, it's a very complex issue to wrap your head around. But
I love that.
overall, yeah.
I want to pick up on two.
Yeah.
You mentioned insulin resistance and you mentioned perimenopause. Can you tell us, I know they're two different things, so pick the one you want to start with, but can you tell us a little bit about what that means? Because not everyone might be familiar with those terms.
Yeah. So insulin resistance is this premise wherein your cells, your body's made up of trillions of cells, by the way, and your cells generally become resistant to the presence of insulin in your bloodstream. So this is important to recognize because insulin is a very important hormone that your pancreas produces in response to the intake of carbohydrates or sugars, because you need carbohydrates and sugars to be able to live, right? Like all your cells, they respond to insulin to be able to get a hold of that sugar to create energy to do their job, right? So at some point, for many different reasons, people become resistant to the presence of insulin, or their cells become resistant to the presence of insulin. And so people develop different issues from that because of how how much how much this function is so important to everything else, right? And so that's the concept of insulin resistance altogether. Very common to see insulin resistance correlated with diabetes, obesity, cardiovascular issues, and all that, because for the most part, you don't really want a lot of insulin in your bloodstream sitting all at once, all at high levels at the same time. Same thing with blood sugar, right? So and that's why there's so many interconnections between different conditions and insulin resistance. Now, how this relates to perimenopause is that it doesn't really cause perimenopause, right? But if under assessed, like, it may be something that could worsen the the poor experiences of people going through perimenopause. So just to kind of take a sidestep to this, with perimenopause, like, it's not a pathology, right? It's something that everyone goes through. People who do end up going through menopause, right? Because it's a transitional period wherein your ovaries start to stop with attempting to conceive. You still are capable of conceiving because you're still technically ovulating. It's just not as consistent as what you would have menstrual cycle wise as you were when you were younger. So with the nature of this event in our reproductive lives, you can expect to see some hormonal changes with perimenopause, and that's where you do naturally become less able to produce estrogen, progesterone, your sex hormones that are involved in your menstrual cycles. So it's very common to see things fluctuate, and sometimes this comes with things like hot flashes and night sweats and sleep issues. But again, not ever normal. It's just very common because of that. Now, again, there's this element of common and normal, but that commonality part sometimes, it can be attributed to that lack of that transitional support almost on a hormonal level. This is where insulin resistance plays a role. It's that because your hormones respond to each one of them, right? Like, it's a very to try to simplify the hormonal role is such a large undertaking. As you can imagine,
it's not simple. Just don't.
It's not simple. Just don't. It's never a linear, right? It's never a linear thing. Like, most of the time, like, hormones are there, they're kind of bunched up all at the same time, and one hormone is going to affect the other hormone in some capacity, and then the other hormone. So it's very it's one of those things that in research we try to understand, like, okay, how do we take this apart, right? This very complex event, how can we take it apart bit by bit? So that's where we're still kind of in the gray area. But we do know, like, in perimenopause, like, there's that general lack of sex hormones, and so that precedes the presentation of symptoms in some people. And so with insulin resistance, sometimes it can be like an enabler for those already disrupted hormonal fluctuations. So especially if not addressed from the beginning, like, it can lead to this presentation because, well, for one, like, having that insulin resistant piece, it can be a disruption to how you normally ovulate, and so it disrupts how you normally produce sex hormones to begin with. And another level, it's something that insulin resistance, you have that presence of insulin, it drives the production or the growth and development of fat cells, and fat cells also produce their hormones too. So then it further complicates that mix. On the other hand, right? So anyways,
And I'm going to guess that if you are under stress, it's like fuel on a fire.
Exactly, right? So it further drives that, like, disarray with hormones. And I think the other piece of this is, like, when we think of people who have symptoms, it's like hormone imbalance is such a bad thing, but in reality, it's a smart thing that your body's coping in that manner because of the situation that it's provided, right? Like, your body's just doing its best, and it's just more like we're not aware of how to support it best at that time. right? So that's kind of been my take. That thought process has evolved from, like, I've evolved for the most part in kind of seeing hormonal imbalance as a message, not necessarily like a super bad thing. It just gives us more clues as to what's happening. So anyway, that's just like an inkling. This is scratching the surface of
But I
of
love your
yeah,
philosophy, because I also believe that the I'm going to use the word design in the broadest sense, but the
yeah,
body is behaving
yeah,
exactly as designed.
yeah.
It's just
Mm-hmm.
not what you want.
Yes, it's just you just never get what you want. That's all.
So,
Such is life.
I want to pick up on sort
Yeah.
of this note of hope that
Yeah.
you had. So
Mm-hmm.
for people who find themselves in this situation where perhaps you are
Mm-hmm.
predisposed
Mm-hmm.
to irregularity,
Yeah.
to PCOS,
Mm-hmm.
perhaps you are predisposed to insulin resistance, and you find yourself in a situation that's of stress, normally through work, right?
Mm-hmm.
A lot of our community are in business development, they're
Mm-hmm.
leaders, they're
Yeah.
entrepreneurs like yourself,
Yeah.
and
Mm-hmm.
in that capacity, there's a lot of stress that comes along with
Yes.
that. So for people who find that they're starting to feel unwell, that
Mm-hmm.
they're not really, their body's not, they know that something's not right, but they
Mm-hmm.
can't really figure out or
Mm-hmm.
articulate what it is. So we're having good conversation. We're starting to
Yeah.
work with a healthcare
Mm-hmm.
provider such as yourself to investigate and perhaps
Mm-hmm.
come to a
Mm-hmm.
picture of what's going on. What are some of the things that you can do on your own as
Mm-hmm.
support? So I'm thinking meals, movement,
Mm-hmm.
mindset, like the things that you
Right.
have access to
Mm-hmm.
in addition to, like, base support, in
Mm-hmm.
addition to working with a healthcare provider
Right.
with more internal supports like
Mm-hmm.
supplements and
Mm-hmm.
medication, and there's a whole host of things available.
Right.
But of course, they're unique to the
Yeah.
person and their needs. But are there some common things that people can do to just lean in,
Mm-hmm.
that can bring
Mm-hmm.
some start to bring some basic relief or support?
Right. Yeah. I think you've pretty much answered some of the things that I would start with as a foundation. And I say this because, like, with hormonal stuff, like, it's very it can be it can be good to kind of start afresh, but it can also take a lot of time to almost DIY the approach, to when you try to figure it out yourself too, right? So there's a balance, but for the most part, the information is there. It's just more like, um, I think, okay, so maybe this is a better way to kind of do it. I start with, like, doing like a head to toe check for everyone, right? Like, if you don't have a healthcare practitioner on board yet, like, and you're still deciding, I think it always is good to just have a realistic way to check in with yourself, know that, okay, try to know what's normal, what's not. So, going through this, what we call it a review of systems when we do comprehensive health checks. So, you know, things like experiences with headaches or migraines, like vision or sensation issues, your eyes, hearing, your sense of smell, congestion, any swelling on your neck, any unreasonable joint aches or body aches and pains. Do you struggle with, like, with maybe what's the word, kind of going on the chest level, what's mobility, maybe mobility is another way to um, assess this, mobility on the upper body, lower body, wherever. And then going down, we look at the cardiovascular system. So looking at, do you experience chest pain or chest tightness? Does it have to do with anxiety? Does it have to do with something that's not related to mood or stress? Do you experience heart palpitations? Do you experience heartburn, right, on the digestive piece? And then kind of on that same note, like, nausea, vomiting, bloating, indigestion, just general discomfort. Are you pooping regularly? So, kind of doing those self checks, right?
I got
Yeah.
to tell you, if you get a chance to listen to one of the previous podcasts, it comes up every time we
All
talk
the
about
time.
health.
I heard
I am
some.
so
Yeah.
comfortable talking
Good.
about it because not enough people
Yeah.
do. Again,
Yes.
what's normal, what's not
Right.
normal. Yeah, yeah,
Right.
absolutely.
Yeah. So, again, like, actually, most people may not be able to kind of do this, right? Just do a self health check, right? Because then, even if you don't have a healthcare practitioner, you can know that, okay, this is something that I can monitor for myself. And then when you have that general level of foundational awareness that, okay, there might be some improvements that I can try to do for, say, my headaches, more my feelings of lightheadedness, then, if you have some general level of what to do for yourself, say on a dietary standpoint, or on sleep support, right? Like see how this can be monitored over, if you give yourself maybe a couple cycles, or 2 to 3 cycles, and then before you call it a day, or call it a month, right? So kind of giving yourself that timeline as well. But yeah, I always start with, like, if you don't have anyone caring for you on a healthcare capacity, at least do it for yourself. Do like a head to toe check as much as possible. And then the rest of the body system is pretty straightforward, right? Like you're working on digestion, you're working on peeing and pooing, and then your mobility, and then so on and so forth, right? So that's a starting point, because then you're not lost. You're not just focusing on one particular body system. So say your periods, right? You can have that sense that, okay, this relates to, my period cramps, or the heaviness in my periods. This seems to be worse when I get more headaches during the month, right? So you can make a pattern. I think that's a big, it's a lot of work that you can really take away from yourself, as if you're doing it every month, right? So start from there, and then say if you haven't gotten any improvements, or any significant improvements after all the efforts that you've put through, say with diet, exercise, with sleep support, with stress, then I think it would be worthwhile calling for extra help, right? But yeah, I think that's what I generally start off with, because there's no, it's really hard to make sure that the treatments that are suggested online would be beneficial to you. But having that extra degree of awareness is always going to be helpful for everyone. Does that?
It makes perfect sense. I mean, we started off the conversation, and I shared sort of my own experience where I knew that something finally wasn't quite right. And with irony, it wasn't that heavy, long periods, even though that may not, from a health practitioner, they're like, oh, that's not common, but it was normal for me. But that's not what the trigger was. The trigger was breathlessness, right? And so what's causing that? Why am I out of breath so easily? And now we're having conversations about like iron and anemia, and then we get into, okay, well, tell me about your periods, right? So I think there's just that awareness, that self-awareness. I love that. I love this idea of the head to body scan, and also that 3 cycles is sort of a normal period of time to give yourself for something to I'm going to call you experiment with, right? And try for yourself, but you need to give it time.
Give it time, as opposed to like 1 week, right? Like I have had to talk to people about, like, if they self-prescribe supplements, like they would likely just give it like 1 or 2 weeks, which doesn't really do too much. So, right, like, so save yourself some time if you're going to try something new on by yourself, provided that you're not going through any emergent situations that require more urgent care. Give yourself more ample time, right? Because hormones don't work as quickly like that, unless you're using stronger medications that are like, actual insulin pumps. Then maybe, it's best to give it some time.
Yeah, because now you're overriding, and that's different, right?
Yeah,
this is not self-support. This is working with a practitioner with additional support. I love this. Kim, I am so grateful for your time this morning. We have gone so much deeper than I had anticipated. I wrote, can you talk about what PCOS is, and how does it impact sort of the bowel and liver and stress, and what is perimenopause? And we're like,
this is great. Like, you're such a natural at just getting the conversation flowing. It's, I didn't even think about like talking about this, but it was so nice to just chat about all of these things, and how it can be important to just develop that level of awareness, because it can take you so far, as you can tell.
Yeah. And I have to say, your skill and your knowledge as a naturopathic doctor has just like totally shone through today. Like, it is so clear how complex we are as individuals, and your ability and knowledge to navigate that at an individual level is just awesome. So thank you.
Oh, thanks, Brooke. I appreciate you having me here. This was lovely.
Oh, my true pleasure. Tell us a little about, where can people find you, if you can just sort of summarize for us.
Sure. Well, I'm here on Instagram. Sometimes I'll be at Brooke's page, but I'm here at Kim Abog ND. I'm also on Facebook, although I'm not there as much, but you can find me on my website. There's an easy contact page wherein you just submit your information, and I'll get back to you directly. So my website is just my name. It's kimabog.com.
Amazing. And you mentioned you're down in the east end of the GTA. Perfect.
Yeah.
And you work with clients primarily in person or in person and
Both.
virtually?
Like I do have that. So yeah, I see people in the GTA, people travel to see me, but I also see people all over Ontario. So there's multiple options with working with me. And yeah, if you have any doubt, just message me. I'll be happy to set up a time to further chat with you so I can, you can understand how I can give support to you. Yeah.
Amazing. Thank you for sharing your wisdom and your knowledge with us today. I really, really appreciate
Thank
it.
you, Brooke. This was lovely. Really enjoyed chatting with you, and yeah, it's an honor. Thank you.
The honor was truly mine. Thank you, everyone, for joining us. Again, I'm Brooke Gordon, and you've been listening to Best for Women Live. Have a wonderful rest of your day. Bye-bye.